Such a big insult to the system. And you find in India the commonest cause of death is heart disease. That they might have an unacceptably high risk of dying.
What if there's a valve in your heart that is slowly narrowing?
So in medicine, there should be a space where there is only the doctor and the patient and nobody else. Unfortunately, that space has got crowded by so many others who are there in the picture.
What is the primary function of the heart?
Cycle of circulation is what keeps life going. Blood vessels that supply blood to the muscle of the heart getting blocked by cholesterol deposit, which is also the commonest cause of death in our country.
Am I possibly suffering from?
You must seek medical attention, especially if you are more than 60.
Is it a fairly risky procedure?
Target should be to try and prevent every single death that occurs from this.
Is it right to say that at that point the heart is fighting?
Till about 30 years ago,
Did you know your heart beats over 100,000 times a day, pushing blood, quietly keeping you moving without asking for any attention until suddenly it doesn't? A short walk starts feeling tiring. The stairs feel more difficult than they used to, and there's a tightness in your chest that you can't explain. You probably think it's age or fatigue, but sometimes it is not age at all. What if there's a valve in your heart that is slowly narrowing, but there is a way to fix it? Not without surgery, not without opening your heart. Let's find out. Welcome to Your Health Matters, a podcast by Kim's Hospitals, where we talk about medical breakthroughs that truly change lives. Joining us today is Dr. Ajay J Swamy, Senior Consultant Cardiologist at Kim's Hospitals, Hyderabad. With over 2 decades of experience and thousands of advanced cardiac procedures, Dr. Ajay J Swamy is a leader in structural heart interventions, including TAVR. Thank you so much for joining us, Doctor.
pleasure to be here, Shreya. Thank you.
We're super excited to learn about your journey and about the topic for the day, which begs the question: what actually prompted you to choose medicine as your career, and even within medicine, what actually drew you to heart as a subject?
Wonderful questions. I've never really thought about them so much. Medicine was always a calling for a very, very long time. In the generation that I grew up in, medicine was one of the most admired professions, and the joy of being able to solve a problem and to make a patient better were powerful motivations. As we start doing medicine, you do an MBBS, a graduation, and a post graduation, and you find in India the commonest cause of death is heart disease. And being a cardiologist offers you the opportunity to save somebody's life in the most immediate and the most effective way immediately.
When we talk about you as a doctor, right, I think the one thing that has stood out for us as well has been patient trust and patient awareness, right?
Mm.
How has that importance for patient awareness sort of emerged, for you as a doctor who's talking to a lot of them on a day-to-day basis?
It's difficult to summarize in a word, but I think one very important word you used is trust. So in medicine, there should be a space where there is only the doctor and the patient and nobody else. No finance, no billing, nobody else. Unfortunately, that space has got crowded by so many others who are there in the picture. And our aim is always to try and communicate what is best for the patient in the given situation, and then everybody else gets into it. And the second part of the answer that you said was awareness. Is with the amount of information available, often patients mistake information for knowledge and information for wisdom. So what is there in social media and on Google is information, but that information is not knowledge, and that knowledge is not wisdom. Somebody who has studied the subject well has got knowledge, and somebody who has studied and worked has experience and wisdom. And unfortunately, you can't confuse the three. So navigating these difficult challenges is the journey of every experienced clinician, not just cardiologist.
Interesting. What is one area where you are particularly keen about, your patients being super aware, right? So, what is the one thing you press on that this is something you must know about your body, irrespective of age, irrespective of symptoms? If you had to, categorize this
Very
information.
often, as we grow older, cardiac disease becomes more and more common as we grow older. And as we grow older, our effort tolerance and the ability to perform our daily tasks and more than your daily tasks also comes down. Sometimes there is a nihilism in which patients feel that I'm old, so I shouldn't be able to do this. And so they miss symptoms which are actually caused by their heart disease, which doesn't allow them to perform the kind of exercise or the kind of exertion that they were doing earlier. Our job is to try and bridge that gap and tell them that this is not because you're old. This is not because you've got a problem with your other organs. This is a problem because your heart is not able to keep up the function as it should be. And so the other organs also are not receiving as much blood and as much nutrition as they should. And they are shutting down. At the same time, aortic stenosis, which is a very, very important and a big problem in the elderly, kind of compromises the heart's ability to pump blood to the rest of the body. And so the heart also begins to fail. So, this double whammy of decreased perfusion to vital organs, other organs becoming less well functioning, and the heart itself beginning to fail, this combination brings about a sequence of symptoms which can very easily be reversed by a good treatment for this common disease.
What is the primary function of the heart, and what does it do on a day to day, minute to minute, second to second basis, actually, that keeps us all running, thriving, and lets you and me do what we're doing right now?
Yeah, so this is fascinating and it is one of the most beautiful creations of nature. So, this is a model of the heart, the long suffering fellow, and this is the left ventricle. This left ventricle's basic job is to pump blood out from here into the rest of the body. This left ventricle is responsible for sending blood to the brain, to the kidneys, to the liver, and to the rest of the body to perform everything that it does. All the blood that goes out from the left ventricle carries oxygen and so many nutrients, and then it's brought back once those nutrients are taken away back to the right side of the heart from what are called the vena cava, that is the big veins that bring blood back to the right side. Then from the right side of the blood goes into the lungs to get oxygenated and comes back into the left side. And so this cycle starts. And this cycle of circulation is what keeps life going. This begins from before we are born, from 6 weeks after conception, till the moment that we die. Now, when this left ventricle pumps blood out into the aorta, which is the biggest blood vessel taking blood from the heart, after it contracts, when it relaxes, this blood will try to come back. To prevent it from coming back, there's a valve here called the aortic valve. And as we grow older, sometimes this valve narrows. As it narrows and becomes thick, the left ventricle has to struggle more and more to pump blood against this narrowed valve. And a stage finally comes when it fails, when it says, I can't take this pressure anymore, and it fails. And that's the natural history of aortic stenosis. When it begins to fail, before that, the decreased blood going out into the other vessels or into the other vital organs also causes changes in the kidneys, in the brain, etc., who are suffering from not enough blood reaching them. That's what happens when aortic stenosis occurs.
Interesting. Is it right to say that at that point the heart is fighting to,
I
do
think
its
that's a
job?
very nice way to put it. It actually continues to overcome this obstruction. It's like there's a mechanical obstruction and it tries to overcome that obstruction. And initially, it's able to compensate and overcome by becoming thicker. And the muscle here, this muscle actually thickens. It becomes concentrically hypertrophied and it tries to push out more. But eventually, it's not able to and it begins to fail. Now, this thickening also makes it difficult for the heart to relax. And so, the pressure in the chamber which fills the heart, that pressure also goes up and that leads to worsening breathlessness
You
and
mentioned a few of these symptoms, actually, doctor: breathlessness, fatigue,
fatigability.
and
Yeah,
other things.
right.
And like we sort of premised this conversation as well, they're very easily,
Missed.
mistook or
Yeah,
missed, especially in old age.
absolutely.
How
Absolutely.
would you say that these symptoms can be differentiated?
Unfortunately, there is no clinical way or some way in which you can ask
Okay.
and distinguish on questions. So you need to perform certain basic evaluation, which is done by a trained professional. A good clinical examination and an echocardiographic examination will tell you whether you have got a problem as far as your heart function is concerned, not only the overall left ventricular function, but also whether the aortic valve is stenosed or otherwise. Treatment for this condition is actually disruptive because if you treat it well, you can go back to having a full and there are so many examples that they go back to a full life and they're able to lead again the quality of life that you can give back to them is amazing. In addition, progressive heart failure has a risk of mortality as well, and you can actually save their life before they go into severe heart failure, before they have rhythm abnormalities, and their other organs also begin to fail. So, This is a very, very important and an easy thing to be done. To speak a little further, till about 30 years ago, treatment for aortic stenosis used to be only surgical. Now, as you can imagine, this is a fairly, big procedure, and it puts a very big load on the heart. So, actually, at one time, we used to only do this for patients who would be able to tolerate it.
Right.
But there were a large number of patients who got diagnosed so late
The
that
body's
they were,
probably not able to
yeah,
take it.
they just couldn't undergo surgery, and they would be kept on medical management, and they would live miserable lives the last few months, or maybe year and a half, couple of years.
Right.
On about 2003, for the first time, a percutaneous technique, that means without putting the patient on bypass, was pioneered by somebody called Alain Cribier. And he created a valve, which was practically made in his own laboratory. And he implanted it. And after that, it was realized that this is a procedure which is possible. That means you don't need to put the patient under anesthesia. We reach the heart through blood vessels either in the leg or in the arm or even in the neck. We put in a catheter through that wire through this blood vessel across the valve in the heart, and then we put in a valve inside that and we deploy the valve there. Now, this is done without general anesthesia. This is done under local anesthesia. So, initially, when it came as treatment for patients who couldn't undergo surgery. So, they tried it in them, and the results were astounding. They found that patients who can't walk to the bathroom are now absolutely fine. They're able to walk, and this was initially only in those high risk patients who simply couldn't undergo surgery. So then they said, all right, let's try it in intermediate risk. So these surgical thoracic societies have percentages of risk, so they put them into low risk, intermediate risk, and high risk. Initially, it was matched against medical therapy for surgical turndowns. Then they tried it for high risk. That means a high risk group was taken, half were subjected to surgery, and half were subjected to this particular therapy. And again, they found that this therapy did actually better because they were high risk for surgery. Many of them would die, would not survive the surgery. But this group did exceedingly well. Then it was tried in intermediate risk. That means patients who didn't have such high risk. They tried TAVR in intermediate risk, and they found it was just as good, if not better. In fact, the valve areas achieved by TAVR, the percutaneous therapy, were actually better. And then they looked at low risk. And there the needle has actually changed, because in low risk patients, the patients who underwent TAVR, they did as well as those who underwent surgical AVR. And so now worldwide, patients are evaluated with aortic stenosis, are evaluated for percutaneous aortic valve replacement. That means for TAVR. Only the TAVR turndowns go to surgery.
If we can actually trace the journey of how aortic stenosis has been treated in the past, if you can throw light on what the original treatment that was discovered was, with the year that the new treatment, which is
Right.
TAVI and TAVR,
Right.
came into the picture, that will be great. And if you can also talk to us a little bit about what are TAVI and TAVR, what do they stand for, what does the procedure include? I know we touched upon it, but if we can talk a little more about just the premise of what are these treatments.
So, as I touched upon earlier, aortic valves, whenever they would become diseased, that means when they would become stenosed, this is essentially a disease of the elder generation. And some people have an abnormal aortic valve since childhood. It's called a bicuspid valve. That means they have two cusps instead of three. And in them, the aortic stenosis occurs about a decade earlier. So, in their 60s. So, in these patients, till about 2003, 2004, treatment was only surgical. So, if they were lucky enough to be diagnosed in time, they would undergo an aortic valve replacement by surgery. And there were two kinds of valves, a metallic valve and a percutaneous or a bioprosthetic valve. The metallic valves require anticoagulation for life. So they were reserved for patients who were operated in their second and third decade, and these valves were mostly rheumatic. That is another cause of disease in young people. But as we have become better in our socioeconomic strata, rheumatic valves have become less, and the degenerative valves, that means the age-related aortic stenosis, has become a much more common cause of aortic stenosis. Now, these would undergo valve replacement surgical over about 50 years or so. So, 60s, 70s, 80s, 90s when it began, and it was the standard of care. Aortic valve used to be treated by surgical aortic valve replacement. However, there was a large number of patients who could not be subjected to surgery because by the time they got diagnosed, it was so late, or they had other organ diseases which were so severe that they wouldn't tolerate the procedure. That means either they had, chronic obstructive lung disease, or they had renal failure, or they had hepatic failure, which would make the whole procedure that we described such a big insult to the system that they might have an unacceptably high risk of dying
Right.
during the surgery. They would be managed medically and they would live out the remaining days of their life, with a very, very limited lifestyle, and have the complications which occur because of heart failure and end organ disease. In 2003, Professor Alan Krieger actually first thought about and did something called the TAV. It was known as TAVI or TAVR, that was transcutaneous aortic valve replacement or transcutaneous aortic valve implantation.
Okay.
So this depends on which side of the Atlantic you came for, but they essentially mean the same things.
Okay.
That means the essential elements are that this would be done percutaneously. That means no surgical intervention. We would put in a small catheter into the groin, which is the biggest artery with which you can access. And through that artery, we would find our way to the heart through these catheters. We would put a wire across this stenosed aortic valve. Initially, we used to have a procedure called balloon aortic valvuloplasty. So we would balloon dilate these valves. But then in a month, they would again narrow. So if you put a balloon and then remove the balloon, the valve narrows again. So he came up with this idea of trying to put in a percutaneous valve sewed on a valve ring, which was inside a catheter. And the ring was kind of folded inside the catheter. The moment you pull the catheter back, the ring would open and the valve would start to function. When he demonstrated that this was possible in 2003, initially everybody said this is gimmickry. But within 3 to 4 years, by 2006, 2007, the procedure became available. It was tested initially, as I said, in the highest risk patients, patients who couldn't undergo surgery for whatever reason. It was proven that it works like a charm in them. They tested it. Then the next step was to test in high risk against surgery. It outperformed surgery in the high risk. Then in the intermediate risk, and it does as well as surgery in the low risk. This has in India, this came in 2016, and we were a little behind because therapy was so expensive that we weren't able to do it.
Yeah.
So some of us actually went and tried to train for this and then started doing this. In India, our journey began in 2016, and we have now been doing it for the last 10 years. In the initial years in 2016, we did about 120 valves, out of which I did 35, and now the number has gone to about 5,000 to 10,000. And potentially, since the number of aortic stenosis is so high, this could go up to 80,000 to 100,000 valves per year in the country. That's because the burden of disease is so large in a country like ours. And that has been our journey. Initially, we had just 2 manufacturers for this, but now we have nearly 10 people whose commercial valves are available. Each valve is different. However, they all have the same principle. That means they have to be delivered into the aortic valve through the femoral artery. As time has gone by, the therapy has taken on a life of its own. And people who have got small femoral arteries, we have other access. We drew it from the subclavian, that means the artery in the arm. And if that doesn't happen, through the artery in the neck, the carotid. And sometimes if that doesn't happen, transcaval, that means we try and get into the aorta from the inferior vena cava. That means from the vein, we make a hole from the vein into the artery when the artery is not there, and then get into the artery into the aorta. So I don't know whom to admire more, the ingenuity of the people who thought of the therapy or the ones who are extending its ability to relieve suffering in so many more.
It's admirable. I think what really caught my attention was when you said groin, like how we send the catheter through the groin,
Right.
but then you said it's also possible through the arm.
Yes.
Or other,
Even the neck.
the neck. Yes. Do you have a model where you can show us something like that, doctor?
What we do when we're doing a TAVR is, this is the percutaneous or the TAVR valve that is in the completely expanded version. This is collapsed inside a little tube in the simplest way. And we bring this tube from a blood vessel in the leg up into the aorta, pass this tube inside this left ventricle, and gradually pull the tube back. As we pull the tube back, the valve uncovers and then seats itself perfectly where we want it to sit. Now, this is done under fluoroscopic guidance, which essentially means a special X-ray and sometimes echocardiography as well, to make sure that it is sitting in the right place. And the measurements are taken by the CT scan that helps us to decide what size of valve to use. This is what the TAVR is. And as you can imagine, we don't open the heart, we don't open the chest, we just go in through a small blood vessel in the groin, in the arm, in the neck, or from some other part of the body. And that's what the TAVR valve does. And once it sits, then it's working, and voila, the heart is functioning perfectly without any obstruction in the aortic valve.
Very fascinating, like you said, doctor. It's extremely beautiful that we're able
It
to
is.
access
It
a
is.
part of the heart through different parts of the body.
Right.
I'm sure this conversation to some extent might lead our viewers to think, oh, is this something that can be that's a possibility? Am I possibly suffering from aortic stenosis? So what would you recommend to our viewers as markers? What are some things they should look out for? Can you guide them, please?
Yeah. Fantastic. I mean, you shouldn't get so scared that you think that everybody has aortic stenosis. First of all, aortic stenosis occurs in normal people beyond the age of 70, 75, maybe even older, right? Except in the people who have bicuspid valve, in whom it occurs a little earlier, 65 or so. And the symptoms usually are fatigability, breathlessness. That means something that you were able to do easily and you're not able to do now. It could be as simple as climbing a flight of stairs and you have to stop to take breath. That means you must seek medical attention. And medical attention means a qualified cardiologist who will look at you and maybe order an echocardiogram. That is the most common way of diagnosing aortic stenosis before it becomes much more severe. If you are not diagnosed at that time, your effort tolerance will progressively worsen, and to the stage where you're not able to walk or even perform activities of daily living. And you could have an arrhythmia, and about 1 to 6%, depending on severity, will have evidence of will have occurrence of sudden death. That means they suddenly have an arrhythmia and they drop dead. And they could have worsening heart failure. That means swelling of feet, the abdomen swells up, the feet will swell up, the neck veins will get engorged. These are the most important set of symptoms. But these are the symptoms in patients who have got only aortic stenosis alone. Very often patients have other comorbidities. They have renal failure, and they have hepatic problem, liver problems, and they have lung problems, etc. In that case, these symptoms will occur much earlier. So the screening might have to be done a little earlier, because once the other organs are compromised, then the importance of aortic stenosis becomes even more. Because if the heart is not able to function the way in which it is supposed to, it becomes a problem as far as the other organs are concerned.
And would you go so far as to marrying certain lifestyle traits, characteristics, or habits to aortic stenosis?
Well, no, not really. Those are more implicated in patients who have coronary artery disease,
Okay.
right? That means blood vessels that supply blood to the muscle of the heart getting blocked by cholesterol deposit, which is also the commonest cause of death in our country. They occur because of certain lifestyles, bad exercise, not enough exercise, bad genetics, bad diet, etc. Aortic stenosis seems to be a combination of your genetic predisposition and the presence of whatever abnormal mechanistic factors which are there. That means you have some tendency to develop heavy calcification of the valve, etc. In any case, beyond 65, it's very difficult to identify things which are going to cause this.
Right.
And as yet, we haven't any evidence that any particular lifestyle is more associated with aortic stenosis. We know certain biochemical markers like lipoprotein small a, dyslipidemia make it occur earlier, but lifestyle wise, there isn't
Not so
really anything
much.
that can change it.
Understood. Treatment wise, doctor, would you categorize the time and the severity of the disease with what treatment you would recommend? Are there options other than TAVR that you usually recommend to your patients?
I mean, I think that's a great question, and this is a question in evolution. The problem with aortic stenosis is there is a significant number of people who have what is called asymptomatic severe aortic stenosis. We judge aortic stenosis severity based on how much obstruction is there at the level of the valve in various patients. Now, when a patient has symptoms, there is no problem at all. You know that this has to be treated, and treatment is mechanical problem, mechanical solution. That means either we do a surgical aortic valve replacement or we do a percutaneous aortic valve replacement. But there is a group of people who gradually decrease the amount of effort that they do. That means earlier he was walking half a kilometer in maybe 4 minutes or 5 minutes, he realizes that he's breathless subliminally and starts decreasing his speed. Now he does the same half a kilometer over 10, 12 minutes. And he says, no, I'm fine. I was walking half a kilometer. I'm walking half now. But he was earlier doing that in 4 minutes and he's doing that in 12 minutes. So he may say he's asymptomatic, but he might actually be symptomatic. So now there is a sensitive set of biochemical parameters, hemodynamic parameters, that means we measure blood pressure in response to exercise, and echocardiographic parameters, that means we actually measure the velocity of blood across the aortic valve and how much of calcium there is. These four things together will decide how severe the aortic stenosis is. Because on the natural history, you can then say, this is your risk of adverse event occurring, this is your problem as far as your heart is concerned, and this is your problem as far as your other vital organs is concerned. And we can sensitively place them as to at what time we need to perform an aortic valve replacement for it. Moderate aortic stenosis, that means where it is not yet so severe, but the aortic stenosis is already there, is a progressive disease. This patient is going to progress and develop severe aortic stenosis. The problem is we are not yet so good at predicting how soon this is going to happen. And this is a group that we are furiously looking at and researching. Is it better to do the valve replacement when it's moderate so that you have solved the problem right in the beginning before there is a problem? But you see, when you do a procedure, there is always a downside. And I said, 10 years later, he's going to require a replacement.
Right.
So if with moderate aortic stenosis, he's able to perform all his exercise and everything, and his other organs are fine, you can probably just keep them on follow-up. I think that is a sensitive medical discussion, which probably it is not fair to generalize on open air. And I think that decision should be made by a qualified professional who's
Basis the
experienced with
case
this.
that
Yes,
they're
this is
looking
a
at.
case to case thing.
Yeah, yeah.
It's a fascinating discussion for doctors, and they keep having meetings and keep having discussions and debates. But the very fact that there is a debate means that there is more than one point of view.
Point of view.
But severe aortic stenosis must be managed as a mechanical problem with a mechanical solution. The nice thing is that we have got wonderful and long lasting and durable solutions for this disease.
Talking about TAVR, doctor, and let's probably dive into a little bit of your experiences with your patients. I'm sure it must have come as a relief to them as well.
Yes,
They're probably,
absolutely.
when you say the word heart, some issue with your heart, because that's how a lay person is, probably perceiving it. Ki heart mein,
Right.
there's some issue with the heart, and I'm probably going to have to undergo surgery. That's probably how the patient or their family is perceiving it. If I'm not wrong,
Yeah.
that's the amount of information or knowledge, misinformation that a layperson is coming in with. So
Yes.
how do they usually react to the option or the availability of a solution such as TAVR, and um, what do their questions look like?
Yeah. I think that's a wonderful question, you see, because when you tell somebody that he has aortic stenosis, as you said, the first reaction is denial, that no, there's nothing wrong with me, let me alone, I'm not undergoing any procedure, no surgery, he wants to run out of your clinic. But then when he realizes that he's symptomatic and he has a problem, in that case, when he comes back to you for a solution, in that if you can offer him an alternative to surgery, that's how it started off. Now it's the other way around. Surgery is the alternative to TAVR. But when you offer him a procedure with which he can walk out of hospital the next day, in the best case scenario, that's really wonderful.
That sounds lovely. That sounds very hopeful
Yes.
as well, doctor. I'd love to hear a story of a patient, a particular
There are
case
so
that
many.
you remember vividly, probably
Every
from your
patient of TAVR is,
first few
is very
towers.
important. So I remember it's a case which I've often shown to, in my own teaching circle, because I teach also. There was a 88-year-old grandfather who was visiting the ENT department along with his grandson
Mhm.
for giddiness.
Mhm.
Now that giddiness was, and while he was waiting for the OPD to show, he arrested. That means he fell down and his heart actually stopped. And so code blue was announced and he was taken on CPR and he was ventilated and shocked back into rhythm. And to our horror, when we were called in to see the patient, we found that he actually had severe aortic stenosis. And the shock was because the aortic valve had narrowed so much that he had a rhythm abnormality and he couldn't put out any cardiac output. So he was so sick that we couldn't do a TAVR initially for him. We did, and we couldn't get him off the ventilator. So we did an emergency balloon valvuloplasty for him. So we didn't do the whole TAVR. We just went in and we did a balloon. and dilated the aorta. That was enough for us to get him off the ventilator. And then after 3 days, we did the TAVR. And this elderly gentleman who couldn't walk, 4 steps, is now playing with his grandson in the park. And he came and presented a pen to us in the OPD. And it was really, really nice to see him walk out with his grandson after a week, joking with each other and pulling each other's legs. There are plenty of stories, but this is something that really stands out, and it shows you how much somebody's life can be changed by a simple procedure.
We've put together some myths and misconceptions that our viewers might have,
No,
and
please
we'd like
ask.
to throw them your way, and you can probably guide us in the right direction.
Please.
So, does TAVR come under open heart surgery?
Not really. Open heart means the patient goes in anesthesia and we open the chest. In TAVR, we don't put a knife on the patient at all.
Is the patient on general
No,
anesthesia
not
for this
at all.
procedure?
We don't give them general anesthesia. In fact, we are moving away. We just give them something called conscious sedation. That means local anesthesia and something just to make him a little less anxious, because we don't want a very anxious patient. But he's fully awake, aware. Sometimes patients give choice of music and we play music for them, what music they want, so they can hear it.
Is it a fairly risky procedure, especially because your patients are mostly elderly?
So as I said, we have a risk stratification for surgery. We have a risk stratification for TAVR as well. But typically, if the TAVR risk is very high, we will not offer him
Recommend.
that
Treatment.
procedure at all. Sometimes you are forced to offer TAVR to patients who have got no alternative. Even in them, the risk is about 3 to 4% or so of a major complication. And that means either bailout, vascular surgery, or something else. You may need to put an additional valve, etc.
Got it.
But the vast majority they come out absolutely fine.
And do the patients need to mentally prepare for a procedure like TAVR, for months?
No, not at all. There's no mental preparation involved. There's just one CT scan which can be done in half a day, and then they're ready for TAVR the same day, because we just need the CT to take the measurement of which valve to put. That is the only time delay as far as the TAVR is concerned. Everything else is not a delay. There's no preparation. I mean, professional preparation. There is financial preparation, but nothing professional.
And after surgery, is there a long recovery period involved? Are they in the hospital for a few days?
Not at all. They go home typically the next day, and there's hardly any recovery time at all. And they are far better than what they were before the surgery, because earlier they couldn't walk at all, and now they can perform pretty much whatever they were doing earlier, and maybe 50% more than what they were doing.
So patients can get back to even, let's say, traveling,
Everything.
physical exercise,
They go back to
activity.
biking. I mean, you must have seen Mick Jagger dancing in the week after his TAVR, performing live.
Singer Mick Jagger is proving that he's got the moves like Jagger. The Rolling Stones frontman posted this video to Twitter showing off his signature dance moves. A little more than a month ago, Jagger had surgery to replace a heart valve. His procedure prevented the band from starting their summer tour, and they were forced to cancel several shows, including 2 at MetLife Stadium. The band says that they will now hit the road.
And and then that's just an example. There are plenty of examples out there, and our patients are no exceptions. They do really well. So there's one patient who went back to his trekking days. I mean, he was 74 and he went back
Lovely.
to trekking, and he actually climbed almost up to the EBC, and he came back.
So do patients have to take lifelong medication after getting the TAVR?
Not at all. The only medicines that they need after TAVR is a blood thinner for about a month or so. After that, for the TAVR per se, they don't require any medicines. Whatever earlier medicines they were taking for their other conditions, that means for their diabetes or their hypertension, those will continue. But for TAVR per se, nothing after a month.
And how long does a TAVR valve typically last?
Right now, the figures with the current generation of valves, it is about 50% to 10 years. That means out to 10 years, half of them will require a replacement. But you can put another TAVR in a TAVR, and that's just another 10 years.
Does having a TAVR restrict future heart treatments if they're needed later?
That's a fantastic question. So elderly patients often have coronary artery disease, etc. Now we have short frame valves which will allow us to do coronary angioplasty even after TAVR, because it's possible that they develop epicardial vessel disease or coronary artery disease after the TAVR. So earlier valves were large and cumbersome and difficult to negotiate to put catheters through. But the newer valves are much, much more friendly, and they're being engineered all the while to make them easier to use and easier to get past.
Are there any warning signs that patients should watch for after the procedure?
After doing a procedure, we typically put them on a follow up plan. And the follow up is 1 week, 1 month, 3 months, and thereafter 3 monthly for a year, and then once in 6 months for 2 years. And during that time, there are certain things which we'll ask the patient to watch for, but they're for individual patients. It's generically there is nothing much.
Nothing.
Once the tower has gone off well, there's not much that one needs to do. Sometimes there is a small leak because of calcium, etc. So then we will recommend a more aggressive follow up for them, or they may require a pacemaker, and then we need a follow up for the pacemaker, or you have done a vascular closure device, and that needs
That
follow up
needs a
for
follow-up.
that. But otherwise, there is nothing like any warning sign that they need to do typically after a tab.
What about MRIs, doctor? Are they able to
No,
get an
they can
MRI?
do. Newer generation MRIs are possible. We don't recommend them for the first 3 months, but after that, MRIs are
MRIs are
possible.
possible.
Very much possible.
Doctor, I don't think we can close this conversation today without touching upon the occurrence of heart issues, heart diseases, and other heart related problems within what is called the younger generation, sometimes sub 50, but sometimes sub 30 as well.
Absolutely.
Why do you think that's happening, and where is this going?
This requires an hour at least, but I'll try to summarize it. In India today, the commonest cause of death is heart disease across ages, across all subsets, right? Especially beyond the age of 25. So, premature coronary artery disease is going to occur in everybody, almost everybody beyond the age of 65. And as age goes up, the prevalence keeps on increasing. There are certain things that make this more likely to occur, like presence of diabetes, hypertension, dyslipidemia, that means a family history, and abnormal lipids. These lipids are the fellows who get deposited. Bad cholesterol is the one who gets deposited in arteries, and these arteries in the heart are very small, 3 millimeters, 4 millimeters is the largest one. And every narrowing actually decreases the amount of blood that the poor heart can get, especially when it's exercising. On top of this progressive chronic coronary artery disease, you suddenly have heart attacks which occur when these plaque fracture and a clot forms on that, and a block goes from, say, 20% to 100%. This has become more and more in the limelight in the last 2.5, 3 decades. There are a lot of reasons which are possibly implicated. The bottom line is that this still remains an important, preventable, and treatable cause of death in the most productive ages of a young developing country like India. Target should be to try and prevent every single death that occurs from this. And by prevent, I mean you start right from changing lifestyle into a more healthy lifestyle, the use of exercise, the changing of diet, the monitoring of high risk parameters in blood, particular time when we image the heart to see has damage already occurred or is it going to occur at various times, say 40, 45, 50. Screening patients who are, or screening people, I shouldn't say patients, who are going for very high risk sport, ideally in many parts of the world, that is part of the screening. And early diagnosis and treatment in patients who have disease. There are multiple barriers to this occurring. In spite of knowing and working in cardiology for 3 decades, it's not always possible to identify in an individual patient. You can identify why it has occurred in a population, and but in the individual patient, there are so many other variables which occur. As a doctor, it's my job to speak on what we definitely know rather than what are the possibilities. What we definitely know is that when the population LDL comes down, the incidence of heart disease comes down. LDL is the bad cholesterol. We do know that populations who are performing a minimum amount of exercise or an optimal amount of exercise have lesser incidence of heart disease. We do know that populations where that are geared up to early diagnosis and treatment have a lesser mortality. Treatment of all these all these issues, there are so many issues here which kind of public health policy, insurance, the amount of, how much the public health system is able to offer, how much private healthcare is able to offer. Suffice it to say that it is important for each one of us to be aware of our risk of possibly developing a heart attack. This is a simple risk which you can calculate based on your age, your family history, these risk factors that you have: diabetes, blood pressure, the presence of addictions, especially smoking, which is one of the most important preventable and infuriating causes of heart disease. As far as I'm concerned, for a doctor, I find it very difficult. We are trying our best to save lives and they're doing their best to kill themselves. It's very, very difficult to swallow. I hope that answers it. I know it's a rambling round question, but I'm choosing my words in such a way that they should not be misquoted. So
I understand your sentiment, Doctor, and I hope our viewers feel that way
I
as well.
hope so. Yes.
Before we close, what would be your one message to our viewers about the TAVR, about aortic stenosis, and about the heart in general?
First, about TAVR, this is a therapy that has come into prime time. This is a treatment for patients who have got severe aortic stenosis. It is a simple, easily available treatment for patients who don't need to undergo surgery. It's a simple solution for somebody with severe aortic stenosis. It is life changing and disruptive. It will extend your life. It will change the quality of life that you have got, that you have suffered so far. And it's easily available. Therapeutic nihilism, saying that no, nothing can be done, don't ever accept that. There's always something that can be done, and we can always help you. You just have to reach the right person at the right time, and treatment will flow from there. Heart disease is something that all of us have to live with. This is something that is part of our population's natural history. This is there in various segments. It's important for us to individualize our own risk, be aware of where we are as far as heart disease is concerned, and take all steps to prevent it. And don't be scared of it. We are very good at treating it. We can offer solutions for many kinds of problems and give good quality of life to people at all stages of heart disease, for prevention, early, late, at every step.
Thank you so much, Doctor. I think this conversation gives hope more than anything else, and I'm hoping our viewers feel that way as well. If you or a loved one is struggling to walk, breathe, or just live fully, don't ignore it. It's not always age. Get yourself checked today. Thank you for
Very much.
talking
It's
to us
been a
today.
great pleasure. Thank you very much, Shreya.
Thank you. That's all for today. We'll be back with another story, another breakthrough, and another reason to believe in modern science. For more details about TAVR, check out the description below.